It's wonderful to be here. I mean, you're all based in New York, right? It's great to be in New York with you, no? But I really wish I were. So my background is psychology, with specialization in neuropsychology, cognitive and clinical neuroscience. And I am principal investigator of neuropsychology here in Belgium, in the University of Liège. And that is my background. What about yours, guys? Because Alfredo said that you are coming from different disciplines, right? So
different stages in the careers as well.
Do you mind if we just shortly introduce ourselves, like the way I see you on the screen, like Chris first?
Yeah, sure.
The first one.
Yeah, I talk a lot in here. I'm Chris. Hi. I'm in New York City now. I'm from Dallas, Texas. I worked as a web developer and photographer for like the past 15 years. And now I'm at Columbia studying neuroscience and behavior on a pre-med track.
Great. I think you will find the part of neuroimaging quite relevant for you. You will see how. Great. Jean-Pierre?
Hi, I'm Jean-Pierre. Most people call me JP. And I've been a professional drummer for the last decade, and I'm back at school 4 semesters in now, studying psychology. And over the next several years, I want to slowly, I guess over the next decade, transition into something more psychology-based, whether it be teaching and or clinical psychology.
Excellent. Et tu parles français? Ou...
Un peu.
Ok.
Oui.
Parfait. Enchantée. Alina?
I'm Alina. I'm a PhD student in the biomedical engineering department, and my research is primarily focused on using ultrasound to increase drug delivery through the blood-brain barrier for treatment of Alzheimer's. So I work a lot on the brain, so this is a totally different perspective, and I'm really enjoying learning about the brain from this perspective.
Great, nice to meet you. Deborah?
Hi, I'm Deborah. I'm currently studying neuroscience and behavior. I'm going into my senior year now, and I hope to study like the intersection of morality and neuroscience, hopefully going into like research soon.
Wonderful, yeah. Neuroscience indeed, it leads to many moral, ethical dilemmas. We will talk today a bit about it. Maybe you'll find it also relevant. Taylor Monique?
Hi, my name is Taylor. I'm currently a part of the Graduate Foundations program, which is a program for students who want to basically get into a either graduate program. So right now I'm taking specific classes to put me on track and kind of make my academic resume a little bit more embellished and better. I have a bachelor's in forensic psychology. So right now I'm just focusing on kind of making my academic career, my academic resume look a lot better. So yeah. Excellent.
You will also see how the issues that we will, they also raise legal concerns. So yeah, excellent, thank you. Andrea?
Hi, I'm Andrea. I'm the TA for this class. So I'm a rising 4th year PhD student in the psychology department. My research focuses mainly on how young children learn from and adapt to their caregiving environments, and how stressors in the caregiving environment lead to changes in emotional behavior and underlying neurobiology. So I use a lot of neuroimaging, mainly MRI, in my research, and so neuropsychology is a little bit different, but I think that it's been fun to provide the developmental perspective of all of the things that we've learned this semester.
Totally, yeah, perfect, wonderful. So you all know what the brain is, I guess, after this class. So I can share my screen, you said, Alfredo?
Yes, you should be able to do so somewhere. In my screen, there's a bar at the bottom that says mute, stop video, and then the green button is share screen.
I think you have to give me permission as a host.
I think I already did.
No, yeah, you're right. I have it, there. Da-da-da. Maybe. Microsoft PowerPoint. I have to give access to Zoom to be able.
There
Okay.
might be also an option in which I kind of force you to share the screen somewhere, or I don't know, there was something about it.
Wait, just
There
one
you go.
second.
There you go. Something is happening. Great.
Yeah, we can all see that.
Perfect.
All right, I'll put you here as a company. Excellent. So I would like to talk to you today about the research we've been doing with a particular type of patients, those that suffer from disorders of consciousness. I hope that nobody of you have had any such experience with a relative, or you know somebody that has been in a comatose state. Did you have this experience so far? Okay. So Chris says maybe.
I have a grandmother that's all kinds of dementia and Alzheimer's. It's a hodgepodge of everything. So she's not quite there.
Yeah. So that's the end part of Alzheimer's. So she's also in this non-communicating state. And it's also a state where consciousness in a way fades away. So today I would like to talk to you about what we learn from these kind of patients, but not from this neurodegenerative perspective, but mostly from the acquired brain injury. Either this is traumatic brain injury, or this is inherent, like stroke, for example. So I would like to introduce you slowly to this state. So this is the case of Terry Schiavo. Maybe you in the US know very well about this case because this is a very highly mediatized patient. So Terry, she had sustained a cardiac arrest, and she was declared as a vegetative state patient in the 1990s. And she was in this condition for many, many years. And her case has been highly publicized in the media because it raised a lot of controversies between her family, her parents, and her husband, mainly because they could not communicate what to do with her case. So the husband wanted to limit treatment and let her die. And the parents were against this decision. And it all had to do with what kind of life she was sustaining in this condition, right? And the husband was claiming that that would be her wish before the accident. Her parents were insisting that she has. And after years of legal battles, it was decided that she had to let go. So they removed the artificial nutrition and hydration, and life took over the course, and she died in 2005. And if you see her reactions to her environment, you will see that it's quite puzzling, right? Whether we can say that whether she entertains some kind of consciousness, some kind of awareness, sentience, like even emotions. So how do we do that in these conditions? Here, typically we try to infer cognitive capacity, so cognition based on motor responsiveness. So if we put these two dimensions in in a graph, we see that when we are in coma, we normally don't entertain any cognition simply because we cannot open up our eyes, even when we're severely stimulated, like painfully. Nothing, we will respond to no external stimulation. But if it happens that we open up our eyes, but we still remain unresponsive to external environment, we're so-called in the so-called vegetative state. Now we call it unresponsive wakefulness syndrome, just to be a bit more politically correct and also clinically correct in the fact that vegetative state typically has been assigned as having no evolution, right? But some patients really show some awakenings spontaneously. So this happens when we have eyes opening and no response to external stimulation. But when patients show some type of higher functioning, like when they respond to a command, like lift your finger or look up, or if they have a mirror in front of them and they follow their image, they said to be in the minimally conscious state. So they're minimally responsive. But interestingly, they're not able to communicate. So they can respond to a minimal level, but they cannot use these motor responses as a bridge, as a way to have a code to communicate. But once we're able to do so, then these patients are not supposed to be in a disorder of consciousness. You cannot see the screen, right? Because you can see what I see. So if I do that, it's better. You can see everything, yes.
I think we can see only your slide. We don't see if there's anything beyond the slide. We can see your pointer as well, but not.
But you cannot see yourself. You don't see yourselves.
No, no.
Ah, interesting. All right.
Yeah, that's
But
Zoom.
you were covering the screen. That's what I'm saying.
We can all move ourselves from the Zoom screen wherever we want on the page. So you don't. But we see only your slide and your pointer.
Yeah. Sorry for that. Just want to make sure that we all see the same thing. So in that case, once we have a mean to communicate with the patient, they are not supposed to be in disorders of consciousness, and now our efforts are made to move from severe disability towards good recovery by means of rehabilitation. But these guidelines don't work for everyone. And interestingly, especially doctors seem to not to agree with each other about what it is to be in a unresponsive vegetative state or minimally conscious state. And we showed that some years ago with a wide survey. So we went at conferences and meetings and we spontaneously asked participants there about their opinions, simple opinions in the sense like in a yes, no answer, whether it is acceptable to stop treatment in a chronic vegetative state or minimally conscious state, right? So we found that the majority found that it is acceptable to stop treatment in a responsive state and less so for the minimally conscious state, suggesting that maybe consciousness in that case that might be mediating this condition here plays a role. So if people think that there is some kind of sentience, they have less willingness to stop treatment. But interestingly, when we ask the same question, but in a fashion that concerned ourselves, like be alive or in a chronic vegetative state or minimally conscious state, medical professionals did not wish to be kept alive in either condition. Significantly, I mean, we see that the proportions quite high. So in that case, there is still a disagreement about what to do when we find ourselves in this condition, especially from the perspective of medical professionals. And we see that even when we asked the question about whether it's appropriate to stop treatment, but in this time with the perspective of pain, so we know that pain is a conscious experience, right? And what would our attitudes, would our opinions change if we think that somebody feels pain or not? So we found that medical professionals agreed with treatment withdrawal when patients do not feel pain. And we see that's so especially for the unresponsive wakefulness syndrome. So what I want to say with all that, I want to say that pain, conscious experience, subjective experience, they all mediate our opinions about what to do with somebody else's condition. And this is troubling because indeed we are called to take a decision for somebody else. And actually we don't really know what's happening in their minds. So how can we do that? How can we come closer to inferring whether there is some type of sentience, awareness, consciousness? I will use these terms interchangeably here. If you were talking to a philosopher, most probably they would have asked you to be more precise with this terminology, but I will use it interchangeably so we don't complicate things. The first thing we can use in order to infer some type of consciousness is behavior, right? But we cannot always trust behavior in these conditions. I will tell you why. So when we started studying these patients, we were receiving from different medical facilities cases. And we followed these cases based on the diagnosis that they came in with. So for example, we had 103 patients that they were in a post-comatose condition, and they arrived to the clinic, 45 of them, they arrived to us with a clinical diagnosis of vegetative state. But when we used a standardized way to assess them, like here is the coma recovery scale, is a classic tool to do so, we found that 18 out of them were actually in a minimally conscious state, suggesting that 40% of these patients have been misdiagnosed. And this suggests that we need at the bedside standardized and specific tools in order to be able to properly infer preserved sentience. And this has to do with specific behaviors, like, as I said, when a patient can follow an object in their visual field, or whether they can follow some simple commands. Sometimes these are not assessed at the bedside as accurately as possible. So what do we need in order to be conscious? First of all, we need a brain, right? And we need a brain that looks typical, that looks healthy, like here, for example, like if we cut our heads from the side, we can see here the corpus callosum, the thalamus, the pons, the cerebellum. It looks beautiful. But do we need all of our brains? Here we can see a case of primary cerebral agenesis. That is a 24-year-old woman that she was born without a cerebellum, the small brain, right? And what happened is that this woman found out that she was missing her cerebellum only when she went to the hospital complaining from dizziness. And she had an MRI, and people found that indeed she was missing this important part of the brain, but she was functional, typical, healthy, all good. And this is the case of an 84-year-old man who also walked into the hospital complaining from dizziness. And when he was examined with MRI, they found this frontal airfield cavity here in his brain. But again, he was communicative, functional, no problem with that, other than complaints from dizziness, about dizziness. So what it takes to be conscious if it's not the whole brain? Well, if we don't need the whole brain, we need, however, to have a functional brain. This means that the material that we have, they need to be connected, communicating in such a way that can support some type, our conscious life. So here I want to show you how this function can be quantified by using neuroimaging. So if we cut the brain here horizontally, we can see different sections of the brain across different states of consciousness. Like here we have typical wakefulness, normal consciousness. We can see here the measurement with PET scan. So it's positron emission tomography. And this is a technique that in that case, it's measuring glucose consumption, right? And the premise is that the more glucose the neurons consume, the healthier they are, because they are functional. So we see that the color scale here is that the more yellow it goes to, the healthier the neurons are, the more functional. So this is the situation of a normal conscious state, and which comes in sharp contrast with brain death, that we don't find any neuronal activity whatsoever. And the situation changes across sleep. We see that in deep sleep, the global metabolism falls up to 50%. It resumes up to normal levels almost during REM sleep, like classically linked to dreaming, but not only. Under general anesthesia, our brains are hypometabolic, so they don't function 100%. And when we recover from anesthesia, we see how we resume our metabolic the energy, the neurons. And then we have the vegetative state. So we see that the brains of these patients hypofunction, but if I show you how some patients recover, it seems that not all of the brain is recovering the metabolic activity. In any case, we need a functional brain in order to be conscious. So some areas that they communicate with some others make all of a difference. Now, how we could do that with neuroimaging? I talked to you about positron emission tomography, but here I would like to talk to you about functional MRI. Do you guys know about this technique a bit? If not, I will give you the basic premise, which measures the blood oxygenation level. So, right, so the idea is that once we're executing a task or we are doing something, our neurons require energy, and this arrives there by means of blood. So the higher the oxygenation of some areas, the more this area is active. And with this technique, we can use different ways in order to infer whether somebody can have some covert type of awareness, right? We can ask these people to, since we cannot communicate overtly, we can ask them to imagine to do some things. And they are so-called active paradigms. So in this study, we followed around 54 patients, if I remember correctly, and we asked them to imagine two tasks, imaginary tasks, like imagine play tennis and imagine visiting the rooms of your house. And these two tasks, they were recruiting in each and every healthy person that we scanned before, very distinct brain areas. So the cemetery motor area, as we see here, for the visiting rooms of your house, we had the hippocampal place area, which is implicated in memory retrieval. And when we asked patients to do these tasks, we found that 5 out of 54, they willfully modulated their brain activity. And we found these patterns in either or both tasks. And interestingly, with one of them, we were able to set a code, a communication code. And in that case, having an interface between computer and brain, where we coined this command as a yes response, this command as a no response, and we're asking personal questions. And in that case, we were able to communicate with the patient with very simple way, whether his father's name is Thomas or something else, and the patient was able to respond correctly in most of the answers. But the last one, if I remember correctly, because it's a very exhausting task, really. The patients have to recruit all their attentional resources in order to execute these tasks, which means that if they don't pass the test, it does not suggest that they are not conscious. So they can be aphasic, they can just be not collaborative or not attentive, right? In that case, this test, it's very highly specific, but not necessarily sensitive. So we're trying to figure out with other simpler ways to infer consciousness. So we can go for passive paradigms, which means that we exert an external stimulation and we check what are the effects on the brain. So here, for example, if you stimulate the median nerve of the wrist with electric stimulation to the point that it's painful, right? Uncomfortable to painful, we can see the so-called pain matrix, like the anterior cingulate cortex, the insula, the somatosensory areas, thalami, and so forth. Now, we don't know, of course, whether patients feel the pain, because as I said, it's a subjective experience and they need to communicate. But what we can say is that they at least have the minimal prerequisites, like the substrate to host this kind of experience. Now, the thing with these paradigms is that they require quite sophisticated setup. So this can be quite problematic in some research centers, or no, research centers not necessarily, but in hospitals where clinics, they have to be fast and doctors don't have time, right? So we're going for the simplest way possible, and that is to scan our brains during rest. So when we do nothing. And actually, when we think we don't do nothing, our brains do a lot of things. And not only our brains, but also our minds. This is the so-called stream of consciousness that was introduced by William James, who is actually so contemporary, even like you can say, like he appears so often in even today in the conceptualization, some concepts of psychology. So he suggests, William James suggested that there is such a thing as a stream of consciousness, because once we are letting our minds wander, this can entertain different thoughts that have different associations, either of the same modality or of different modality. And we can think of the future, of the past, we can think of images, right? And this is unconstrained stream. And we think that with scanning our brains during resting state, we can capture some properties of this stream. And let me give you some numbers of what a resting condition of the brain looks like. So we know that the brain is approximately 2% of the body's weight, and 80% of its energy is spent on neuronal signaling. And only around 5% of this energy is about stimulus and performance evoked changes. So which means that while is a low bandwidth phenomenon and therefore energetically inexpensive, it is dependent upon a very complex, dynamically organized, non-conscious state of the brain that is achieved at great expense. So there is such, the way I visualize it is like a kind of a lava, right? That there is some dynamism, like this thick material that moves around all the time. And from time to time, we'll have like a blob of a small spur of lava. And that for me could be, for example, neuronal functioning, which goes back to the background. So, what happens in our brains when we do nothing? So it seems that they are very well organized indeed. And that was found out in a very peculiar way, actually, because in experimental designs in the fMRI, we have typically a task and then a control condition. Like, for example, in many cases, there was a resting condition with fixation or eyes closed, right? And when we would do the contrast, people found out that there were some areas of the brain that they showed systematic deactivations during the rest, mainly. So these areas encompass posterior cingulate, the precuneus, anterior cingulate cortex. And so if we take the signal, the bold signal, which is what is measured by the fMRI, right? And they found that these areas were changing together across time. The proper term for that is that they were functionally connected. So there is functional connectivity between these two regions, which actually means correlation. And so people propose that there must be then a way that our brains work by default. And this is the very famous, maybe you have heard of it, the brain's default mode network. Here we can see the midline of the network, anterior cingulate cortex, as I said, mesiofrontal, and posterior cingulate and precuneus. This is the classic picture of the network. How can this default mode, inform about the state of consciousness? So what we did, we checked how connectivity in this network changes from healthy people to minimally conscious state, vegetative state, and coma. And we found, if you see, a decrease in the functional integrity of this system as we move across the spectrum of consciousness. But interestingly, the default mode network does not come by itself. It's related to other systems in the brain. Here we can see the most important system that it relates to, but in an opposite manner. So the default mode are the correlation. So we see here the DMN and the classic way, as I said, and the anticorrelations, they refer to frontoparietal regions here in blue, but also occipital regions. And we see here, if we plot them against time again, we can see these anticorrelated activities. So the DMN is here, the anticorrelations, of course, they go other way around. And this system, an agonistic way of system relation, we think that it can inform us also about the state of consciousness. And not only about the state of consciousness, but specifically about the state of awareness, about how we report about our conscious, about the contents that we have in our heads. So if we had this this idea that the internal the default mode network is representing the internal awareness, and it's not only from our work, but based also from work from other labs, which means that the default mode network was correlated with content about self-related thinking, like projection of ourselves to the future, to the past, inner speech, and all these things that they are happening in our heads. Interest to the correlated network that entertains mostly perception of the environment. And here again, we see how these two anticorrelate across time. We did a very similar, very simple experiment with healthy people at the beginning. So here I show you the results that we found with behavior. What we asked people to do is that to sit quietly with eyes closed in front of a computer, and they had to use both of their hands. One hand was was representing their internal awareness, and the other their external awareness. So from time to time, people were hearing a beep, beep, and then afterwards they have to give a rating about their external and internal awareness as it has been before the beep. And in that way, we could see whether we still find this way of anti-correlation also at the behavior, not only at the brain. And indeed, we did find that. We found that at behavioral level, these ratings anti-correlate, switching their dominance on average every 20 seconds, which was quite similar to what we found with the fMRI. When we put people in the scanner, and now the rating was a bit a bit simpler. Now people had to say from time to time whether they've been strongly internally oriented or strongly externally oriented. And we found that when people were saying, I'm very in my head, totally in my thoughts, we found the DMN, the default mode network. And when people saying that I'm strongly influenced by my environment, I was hearing, for example, the scanner, or I was paying attention to something around me, we found the external control network, the anti-correlated network. So with this study, we found the cognitive behavioral counterpart of resting state. And in that case, we came a bit closer to decipher the content of this anti-correlated system. Now we have to go on with controls, right? With some controls. What happens if we modify our state of awareness? How can we do that? By also being able to report. So we thought so to do it with by means of hypnosis. So hypnosis here was induced by our trained anesthesiologist, who she uses this technique at the hospital, so people can have surgery without anesthesia, give birth without anesthesia. And this is very crazy. I mean, I'm telling you, I just gave birth like 6 months ago, and I wouldn't go for that. It needs some discipline in order to do so, some training. Very courageous people. In any case, she helped us use this technique in order to modify the content of awareness. So what we did, we scanned healthy people under three conditions, like normal consciousness, during a condition of autobiographical mental imagery. This means that we asked them to imagine a pleasant memory, like holidays. And we asked them to do the same after hypnotic induction. And so behaviorally, we saw that here during hypnosis, people reported to be mostly absorbed into this state compared to the other two conditions. They reported they were dissociated from the surroundings, so they were totally in their thoughts, like they were reliving the experience, and they had fewer thoughts about their environment during hypnosis. So when it comes to the brain level, contrary to our hypothesis about the default mode network that did not really modulate in terms of functional connectivity, we found that actually the anti-correlations were those that they almost were diminished in hypnosis. So we see here the functional connectivity of the external control network in normal consciousness, and hypnosis, it almost disappears, which goes very well with what people say that I was totally dissociated from my surroundings. The other test we did, we wanted to see what happens if we controlled for the state of arousal. What happens to the anticorrelations, right? And we did so by inducing people into a state with a propofol anesthesia. So here we see the DMN and the anticorrelations during wakefulness, and we see here again that DMN persists even though it's significantly restricted, but mostly it's the anticorrelations that they disappear during propofol anesthesia. and I don't have here the other slide, but it would be, what we also found in this paper is that once we recover from anesthesia, we also recover the anticorrelations. These anticorrelations also seem to be sensitive to the environment. And here I would like to show you a very funky experiment. Are you familiar with a parabolic flight? Do you know what it is? Excellent. For you that they don't know, you don't know. Because this is a very peculiar study that we did in collaboration with European Space Agency. So we introduced, we participated in a study, the Brain DTI project, where we scanned the brain of cosmonauts when they leave the Earth for the International Space Station and when they come back. Part of this project was simulations of microgravity. One of the simulations is induced by parabolic flight. So parabolic flight is a campaign that happens once or twice a year, where this special plane flies over Bordeaux, over the Atlantic actually, and has this peculiar parabolic movement where it increases, I say, the speed by moving upwards. So in this condition, we are exposed to a hypergravity up to 2G, and then it's in free fall. And during these 20 seconds, there is loss of gravity. And the plane afterwards stabilizes, trying to stabilize back to normal steady horizontal flight, which means that we're again exposed to this hypergravity. But let me show you what happens in the flight. So this is me. And I'm very happy that I participated in this experiment. It was the second craziest thing I've done in my life. So you can see here how hypergravity, the microgravity is on. We're free floating. And now hypergravity is happening.
Whoa.
And we had to do that 30 times. It was crazy, and I'm telling you that subjectively, it was the biggest illusion I was experiencing was the inverse illusion. Like during the microgravity phase, I could not tell what is upwards and what is downwards, and I was really trying to pay attention not to land on the ceiling, right? Because it could be very dangerous for the leg. Anyways, that was a very crazy experiment that we were part of it, and after we participated, we flew directly into the scanner. And we had the scanner the day before and the day after, and we analyzed our data, and we found that what happened after the flight here, it was a modulation of this part of the brain, the right angular gyrus. And if you talked already about stroke and so you know that this right parietal part is quite sensitive, and it represents a lot about the part of our bodies, right? So this is what we found in the sense, like our bodies, our brains understood that our bodies really felt uncomfortable in this condition of microgravity and very special condition of lack of gravity or even hypergravity. So when we checked how this region correlates with the rest of the brain, we found the DMN and the anticorrelations. So here in red, it was the default mode network, the anticorrelations, and the contrast of the pre-flight and the post-flight showed that it was the anticorrelations we see here that they were so nicely at the pre-scan, at the post-scan they were less, fewer. So this anticorrelated activity is also sensitive to environment. And the last test we did, it was how does they look like in disorders of consciousness. So here we see again the DMN as I showed before, that how it looks like in unresponsive state, minimally conscious. Patients who have exited the minimally conscious state, they're healthy and healthy people. So the DMN is there, it persists. The anticorrelations, however, appear only in those subjects and healthy people that they can communicate. In non-communicating conditions, they even go on the other side. This is to show that we have good reasons to believe that once we find this anticorrelated system, we can have a good reasons to believe that patients entertain some kind of consciousness. But we know that there are many networks, resting state networks in the brain, that they even can reflect some type of cognitive content. Like here we see at rest the motor cortex, how when we don't do something, our brain is already wired to host motor tasks. So you see here this map, how similar it is when we actually have a finger tapping task, and how so many networks around the brain exist. When we checked what happens with so many networks in the brain, in patients, we found that, not surprisingly, it was the default mode network, the anticorrelated executive control network, the left, the right, that they were more disrupted in patients. But also what we did not expect is that the auditory network, we see here how the areas of the system are disrupting the patients. And we thought, like, why the auditory system? It's a sensory network. Normally, why this would not be the case in patients? How come this is the case? So by that time, we did not have enough power to discriminate patients based on their on this network. Later, we found a way to include all patients, and by trying to answer the question, which network discriminates best in patients, right? Because this is actually our question, like how we can use the functional fMRI during resting state in order to say something meaningful about the clinics. If we have a collaborator in New York and they sent us like a 10-minute scanning, how can I make sense of whether this person is in unresponsive or minimally conscious state? So if we analyze all long-range networks like the DMN, the frontoparietal, salience, which is involved among others in pain, but also sensory networks like auditory, sensory motor, visual. If we try to see how these are discriminating patients, we found that the auditory system was the one that did a very good discrimination. So out of 45 patients that we had in total, it was able to separate properly 43. And it was like, then the question was like, again, the auditory system, how would that be the case? Well, if we see how the auditory system looks like, and if you know a bit about functional neuroanatomy, you see here the auditory areas, right, on the right and the left, but also it was visual cortices. And this cross-modal interaction seems to be of significance to support consciousness. This is because when we try to use this pattern in order to predict whether patients, new patients, were in minimally conscious state or unresponsive state, we found in blind data, so new data from colleagues from Cornell over there, like the group of Nico Schiff, but also in Salzburg, collaborations in Austria, we found that 20 out of 22 patients were able to discriminate in an accurate way. This means that the doctor and the algorithm, the pattern, were in agreement for most of them. And indeed, this way of cross-talking is what I said at the beginning. Like, it's not so much the matter of how much brain we have, which of course plays a role, but it's mostly a matter of how the connections between the brain happen. Alfredo, do I still have time?
Exactly. Just a few more minutes. Not a lot of minutes. Right?
Okay. Because all I wanted to show is that all this happens if we average the signals all around the brain, right? But we know that the interactions, the ongoing interactions, brain regions happen across time. So this, we're interested in the dynamics. So here, for example, it's a representation of our brains, but at the signal space. So each line here represents one area against another area. And we see how the areas talk to each other in a very complex way. So the red means that they mostly correlated, the blue means that they are less correlated, and across time we see that our brains dynamically change from one pattern to the other. But what happens when we are in a state of anesthesia, for example? This is in monkeys. So we see that in anesthetized monkeys, the areas don't talk a lot to each other. So the correlation is around zero. And when we try to see how this pattern looks like in patients, we also found that across time, there are different ways that the brain configures. So we found a very complex way, as we see here, and a very simple way. So areas that they don't talk to each other. If we see here, the correlation is around zero. When we try to see in which conditions these patterns appear, we found that we have unresponsive, minimally conscious, and healthy people. We found that this complex way appears mainly healthy people. And this very simple way is prominent in unresponsive patients. So I don't want to go into so much into the methods, but I want to say again, why does it all matter? So why we come at great lengths in trying to find consciousness in these people? Well, this is because we have to take decisions for others. And these decisions are really based on what we think about what happens in these conditions. So we need to rely on the tests and on the clinical examination, the clinical assessment. And there are three scenarios, right, where the doctor and the tests can be in agreement or not. So they are not in agreement, so we have a test that the brain activity is less than the neurological examination, and this has benefits and harmful effects. So if a test does not show high activity, then the good thing is that the relatives arrive to the point to make decision to limit life-sustaining treatment. But if the family is not ready enough, they may lose hope, purpose, and meaning. If a test now has higher activity than the neurological exam, then the good thing with that is that the clinical management may be intensified by putting our bets on further recovery. But if this doesn't happen in the long term, then the relatives may have suffered from false hopes and be in a limbo whether to hope or not to hope. And of course, the best case scenario is that we find a condition where the neurological examination is confirmed, and only with this way we can make a proper rehabilitation planning for patients. Yeah, it has to do a lot about quality of life. We cannot say anything about quality of life in patients. I don't want to go deep into that, but all I want to say is that at the moment we are trying to say that the whole story is not only about the brain, but rather now we have to integrate the body. So the interactions between the brain and the body and the environment provides a more holistic approach to the study of consciousness. And this is how my lab is focusing on from now on, by analyzing more peripheral data like electromyography, oculography, and electrocardiography, ECG. And yeah, for example, here is the ocular responses when we stimulate the inner part of the ear. So in a way we disturb the system, the balance system, and by measuring the nystagmus, we can say a lot of things about reflexes and how these change under different contexts. So to conclude, to give you some take-home messages, consciousness needs a brain, right? Which is intrinsically organized, shows complexity, and also dynamic flexibility. It's about brain-body interactions, and to my understanding, it's consciousness is a part of it's a kind of collective consensus. We all need to agree of what it is, because it's not like a phenomenon that is there or not there. We have to be in agreement of what it is like. In that case, for me, it means that this term is still fluid, and its definition, it's still ongoing, and its research is still very rich in order to understand more globally of what essentially is this part of subjective experience. Thank you guys so much for hosting. I hope it was not too much loaded.
It's great. It's great. It's great.